Hi, my name is Dr. Hang Quach. I'm one of the haematologists who treats multiple myeloma at St Vincent's Hospital. Through this talk, I hope to be able to give you an understanding of what myeloma is and be able to convey to you the type of progress we've made in this disease over the last 10 years that's really made it one of the most treatable out of all the different type of blood cancers we have in present day. As an overview, I'm going to be discussing what myeloma is, the type of treatment we have for myeloma today and the promising ones in the future. I'll be touching on clinical trials, and I'll be talking a bit more on supportive care and measures to keep well, because this is important as myeloma patients are now living much longer now than ever before. Multiple myeloma is a type of blood cancer. A lot of people mistakenly think it's a cancer of the bone, but in fact it's a blood cancer that often affects the bone. So as depicted in this picture here, in our body we have a factory that makes blood called the bone marrow. The bone marrow makes many different types of blood cells, each with different function. So we have the red cells that carry oxygen around the body and gives you energy. We have many different types of white cells that help you fight infection. And then we have platelets, which are cells that stop you bleeding and form blood clots every time you have an injury. There are many different types of blood cancers, each that can affect any different subset of these cells, and multiple myeloma is a type of blood cancer that affects a subset of white cells called plasma cells. Now, in healthy people, these plasma cells are actually professional immune cells that make antibodies to fight infection. In multiple myeloma, these plasma cells are actually cancerous, so they overgrow and invade the bone marrow. As they do so, they produce abnormal antibodies called paraprotein or M protein that we can detect in the blood or in the urine. Left untreated, the myeloma cells can produce multiple systemic complications and end organ damage. For example, there will be decreased production of normal blood cells, so a person can have anemia, that is low red cells, causing tiredness, shortness of breath, and decreased exercise tolerance. A person can have low white cells that can lead to increased risk of infections, and low platelets that can lead to increased tendency to bruise. As the myeloma cells grow, they themselves produce chemicals or cytokines that can destroy the bone. And this can cause osteoporosis or fractures through small areas or small holes in the bone. And this can cause generalized bone pain or quite severe focal bone pain. As the bone is damaged, the calcium can leach out of the bone, causing high calcium in the blood. And this can lead to constipation, tummy pain, and if severe, it can cause kidney impairment as well as confusion. Now, because people with multiple myeloma have low levels of functioning antibodies, in addition to the low white cells, you can see that most people with myeloma are at risk of getting infection. And importantly, people with myeloma are at risk of kidney damage because the light chain component of the paraprotein are toxic to the kidneys. So in summary, multiple myeloma is a blood cancer that affects a type of white cells called plasma cells. It's often associated with a production of a paraprotein, that is abnormal antibodies, and can contribute to systemic complications or organ damage if left untreated. So as mentioned, paraproteins are abnormal proteins that are produced by the myeloma cells. Your specialist will measure these paraproteins to monitor how the myeloma is going, so I just want to explain briefly. The paraproteins that are produced by the myeloma cells are oftentimes a whole intact antibody, otherwise known as immunoglobulins, or Ig for short. And they usually consist of 2 heavy chains seen in white here and 2 light chains seen in black here. So oftentimes, a person can have an IgG multiple myeloma, which is the most common type, or an IgA myeloma, or less likely, an IgD multiple myeloma. In 10% of cases, the myeloma cells will only produce a component of the whole antibody, that is, the light chains. And so a person can have light chain multiple myeloma, that is, lambda light chain or kappa light chain. Whatever the paraprotein that the myeloma cells produce, your doctor will measure the same protein again and again to monitor the progress of your disease. The reason why myeloma is called multiple myeloma is because of the multiple patchy involvement all over the body. This PET scan here is a scan that shows areas of activity of disease, and you can see here the patchy involvement, typically involving the skeleton, but multiple myeloma can also exist as a soft tissue mass called a plasmacytoma. In order to diagnose multiple myeloma, we have to prove that there is an excess of abnormal plasma cells or myeloma cells within the bone marrow. So a lot of people will have to undergo this process. It's a very simple procedure. The procedure itself often takes only about 5 to 10 minutes. So we often ask the patient to come into hospital as a day case. We ask the patient to lie on a bed in a curled up fetal position like this. We give the patient light sedation and then lots of local anaesthetic around the pelvic bone. We then insert a slightly larger needle into the pelvic bone, and then into the bone marrow. We suck out some bone marrow and smear it on a slide, and this is called a bone marrow aspirate. We also obtain a core of bone to look down the microscope. So under the microscope, this is what we see. On the left-hand side, you'll see a picture of a bone marrow aspirate, and the myeloma cells often show up as a cluster of quite large cells that is purplish in appearance with a round nucleus that is situated eccentrically to one side of the myeloma cells. On the right side, you'll see a bone marrow trophine, and this trophine is stained with a special technique called immunohistochemistry, and this light up the myeloma cells as brown patches. And so you can see here there's a brown patch of myeloma cells within the trophine. Not all people who are diagnosed with multiple myeloma require treatment, and this is because the process of development of multiple myeloma often happens over a long period of time and is almost always preceded by a phase called MGUS, and this is a precancerous phase. So there are basically 3 phases to the disease. The first phase is called MGUS or MGUS, and this stands for monoclonal gammopathy of uncertain significance. And this is when the amount of abnormal plasma cells are only small within the bone marrow, typically less than 10% of the bone marrow space. The paraprotein that are produced by the myeloma cells are usually small to moderate in quantity. But importantly, there is no evidence of myeloma-induced systemic complications or organ damage at this stage. So this is a sleeping stage, so to speak, and the person is usually completely well at this stage. We normally don't offer active treatment for myeloma at this stage because there's yet to be any evidence that treating patients at this early stage will make the patient live any longer. Now, as the myeloma cells grow and occupy more than 10% of the marrow space, this is called multiple myeloma. But again, if there is no evidence of systemic damage or organ damage caused by the myeloma, this is called smoldering myeloma or asymptomatic multiple myeloma. Again, at present time, we do not offer active treatment at this stage because the disease is relatively quiescent or asleep, so to speak. When the disease is awake, it will cause the type of end organ damage that we spoke about, typically anemia or low red cells, renal damage and bone damage, etc. And we call this symptomatic multiple myeloma. This is when the person will require treatment. The risk of progression from MGUS to symptomatic multiple myeloma varies, but it's typically about 1% per year, that is 1 in 100 chance per year. The average time to progression from smoldering multiple myeloma to symptomatic myeloma requiring treatment again varies, but is typically between 1 to 3 years. So how common is multiple myeloma? Worldwide, approximately 4 in every 100,000 people will have multiple myeloma. In Australia, about 1,500 to 2,000 new cases of multiple myeloma are diagnosed each year. Multiple myeloma occurs more commonly in men than women, and I don't know why. The graph shows the incidence rate for multiple myeloma according to different age groups, and you can see here that the rate of multiple myeloma increases with age. The average age for diagnosis of multiple myeloma is between 65 to 70 years old, but multiple myeloma can exist in much younger patients in their 30s and 40s. The number of patients diagnosed each year with multiple myeloma, and you can see that this number is increasing. And the reason for that is that Australia, like most other first world countries, is an ageing population. That is, a larger proportion of our population are more elderly, and that is because we are now living longer and our birth rate remains low. Let's now talk about treatment of multiple myeloma. The treatment of multiple myeloma have progressed quite profoundly over the last decade because the number of effective and new treatment we have for myeloma continues to increase. The discovery of these new agents is largely owing to the fact that we now have an improved understanding of how the myeloma cells grow and invade the bone marrow. Cancerous myeloma cells normally start within the bone marrow. Within the bone marrow, they act like parasites in that they bind very strongly to the surrounding cells, chiefly the bone marrow stromal cells. And they do this by developing on their surface very sticky molecules called binding proteins or adhesion molecules. Once the binding takes place, many things happen. The first is that the myeloma cells can stimulate the production of growth hormones produced by the surrounding cells to promote its own growth. Secondly, is that the myeloma cells can produce or induce the production of blood vessels to carry nutrients and oxygen to again promote its own growth. As the myeloma cells grow, they themselves can produce more growth hormones to support the surrounding cells, and this is to establish a very fertile and supportive microenvironment in which they can grow and strive. Now, before the 1990s, the only treatment we had for myeloma was chemotherapy that works mainly by killing the myeloma cells. The newer agents we have today attack this process via many ways. Not only does a newer agent attack the myeloma cells, in addition, they also block the development of binding proteins, so preventing the myeloma cells from sticking to the surrounding microenvironment. Secondly, the newer agents can block the formation of blood vessels. They can also block the formation of growth factors. So already you can see why these new agents are going to be so much more effective than just chemotherapy alone. So two important groups of drugs that can carry out all of these activities are the immunomodulatory drugs, otherwise known as IMiDs for short, and proteasome inhibitors. Both of these groups of drugs were discovered in the late 1990s and early 2000s, and they've really changed the landscape for treatment of multiple myeloma. Currently, there are a number of drugs within each of these families, but the ones that are available for routine use in Australia include thalidomide and lenalidomide, otherwise known as Revlimid, and both these drugs belong to the immunomodulatory groups of drugs. And then we have bortezomib, otherwise known as valcade, and they belong to the proteasome inhibitor group of drugs. We also use chemotherapy to treat myeloma nowadays, and the common chemotherapy we use are melphalan and cyclophosphamide. Then there is another group of drugs called corticosteroids. And these drugs are well known for their anti-inflammatory effect, but they also kill myeloma cells quite effectively. Examples of corticosteroids are dexamethasone and prednisolone. The corticosteroids are known to increase the effectiveness of the immunomodulatory groups of drugs and the proteasome inhibitors when they are used in combination with these drugs. So oftentimes a patient will be treated with a combination of either a immunomodulatory drugs or a proteasome inhibitor with a corticosteroids, and oftentimes with a chemotherapy. Let's now talk about some of the common drugs that you will likely come across. So thalidomide, as mentioned, belongs to the immunomodulatory group of drugs. It exists as a capsule that can be taken by mouth every day. When used on its own, it's effective against myeloma, but it's especially effective when used in combination with corticosteroids and chemotherapy. This drug is generally quite well tolerated, but there are some common side effects that you can expect. The first and most important is perhaps peripheral neuropathy, that is nerve damage, which normally doesn't occur until after about 3 or 4 months being on the drug. Oftentimes it can start off as mild numbness and tingling in the hands and feet, and if it's mild, it's usually reversible, so your doctor may choose to continue on with the same dose. However, if it gets severe to the point of causing a burning sensation or weakness, it may not be reversible, so you need to tell your doctor in time to stop the drug. Constipation is also a common side effect. Usually, however, this can be managed conservatively by increasing fibre in the diet. Some patients will require laxatives. Sedation is also quite common, and so we ask you to take the drug at night. There is a risk of venous thromboembolism, that is blood clots in the legs and lungs. So we do ask patients to take a blood thinning agent such as aspirin and sometimes equivalent agents such as clexane or warfarin. Importantly, there is a risk of birth defect. Some of you may recall that in the 1950s and 60s, thalidomide was used as a morning sickness pill for pregnant women. And this resulted in serious birth defect, resulting in the prompt withdrawal of the drug off the market. Currently, all patients who are on thalidomide need to be registered on a registry, and women of childbearing age or potential or men who are in relationship with women of childbearing potential must agree to appropriate contraceptions to prevent pregnancy. Now, lenalidomide, otherwise known as Revlimid, is a chemical derivative of thalidomide. It was designed so that it could be more effective than thalidomide, but with much less side effects. This drug was discovered in the 1990s, late 1990s, but was made available for use in multiple myeloma approximately around 2003. It exists as a capsule and typically is taken on a daily basis for 3 weeks, followed by 1 week break. Again, this drug is extremely effective in the treatment of multiple myeloma, but is even more effective when we combine it with corticosteroids and chemotherapy. Now, unlike thalidomide, lenalidomide does not cause peripheral neuropathy or nerve damage, rarely causes sedation, and only very occasionally causes constipation or diarrhea. The main side effect of this drug, however, is that it can suppress the bone marrow so that a person can develop mild anemia or low white cell count, but usually this is quite manageable. There is still the risk of venous thrombosis, that is clots in the legs or in the lungs, so we still ask patients to take a blood thinning agent such as aspirin. The requirement for birth control is the same as thalidomide because both of these drugs belong to the same family. Then we have bortezomib, otherwise known as valcade. This drug belongs to a completely different family called proteasome inhibitors. It was discovered around the same time as lenalidomide and was in clinical trials at around the same time and was available for the use in myeloma around 2003. This drug exists as a powder that can be made into injections either through the skin or through the veins. Now, traditionally, we used to give this drug twice weekly, followed by 1 week break through the veins. But we now know that if we give the drug through the skin and on a weekly basis, we reduce the side effects without compromising the effectiveness of the drug. So the trend now is to use the drug on a weekly basis and through the skin, not through the veins. This drug, again, is quite effective in the treatment of myeloma, but again is especially effective with combination with dexamethasone, that is corticosteroids, and chemotherapy. Like thalidomide, it can cause peripheral neuropathy, that is nerve damage. Again, you must tell your doctor if it gets severe because it may not be reversible if the drug is not reduced or stopped in a timely fashion. Diarrhea is also common with this drug, but usually it's quite self-limiting. There is also an increased risk of shingles with this drug, so oftentimes your doctor will ask you to take an antiviral agent, for example, Valtrex. Next, I want to talk about autologous stem cell transplant because this is still one of the main modalities of treatment of multiple myeloma nowadays. And it remains one of the most effective methods we have to reduce the burden of myeloma in patients. So we often offer it to younger patients after their initial treatment as a consolidative means to further improve their response. So just briefly, the whole procedure is as follows. The initial phase of treatment is called induction therapy. And induction therapy serves to reduce the initial burden of myeloma cells within the body at first diagnosis. Induction therapy often is a combination treatment using combination corticosteroids with one of the newer agents, either an IMiD or a proteasome inhibitor with a chemotherapy. This normally lasts for about 3 to 4 months. After induction therapy, the person will undergo a process called stem cell mobilization. And this is when we give patients injections of a hormone called GCSF or filgrastim. And this hormone will stimulate the bone marrow to produce stem cells. Once the stem cells are produced and moved out into the peripheral blood, they are then collected via a cannula, placed in the main veins of the body through a process called apheresis. Once sufficient stem cells are collected, they are then frozen at -70 degrees. For the actual stem cell transplant, we electively admit patients into the hospital. We give the patient high-dose chemotherapy called melphalan. This chemotherapy will wipe out the current existing bone marrow where the myeloma cells live. We then reinfuse the stem cells back into the patients approximately 24 to 48 hours after the chemotherapy. These stem cells will migrate back to the patient's bone marrow and regenerate to give the patient a whole brand new bone marrow in approximately about 3 weeks. The type of treatment that a patient will get will depend on his or her age and fitness level. Generally, we categorise patients into 2 groups. Patients who are fit for stem cell transplant, and these are patients who are generally under the age of 65 years, or even older patients up to the age of 75 years who are fit, or patients who are not fit for stem cell transplant, and generally these are patients over the age of 75 years. For patients who are fit for stem cell transplant, we offer induction therapy like we discussed, followed by stem cell harvest, and then stem cell transplantation. After stem cell transplantation, we offer patients maintenance therapy in the form of a thalidomide tablet for up to 1 year. And this is because there's been evidence from clinical trials to show that maintenance therapy do improve people's outcome after stem cell transplantation. For patients who are not fit for stem cell transplant, we offer induction therapy that can last for about 6 to 12 months. After that, the patient may or may not continue a smaller component of their therapy until disease progression, called maintenance therapy. By treating patients this way, and by the routine incorporation of lenalidomide, thalidomide and bortezomib into treatment, we've now shown that the survival of patients with multiple myeloma have improved dramatically since the turn of the century. So the blue line here shows the survival of patients with multiple myeloma who were diagnosed between the years 2001 and 2006. The purple line here shows the survival of patients who were diagnosed between the years 2006 and 2010. The survival curve in 2015 is expected to be much better than this. But you can see that such a big improvement over such a small period of time is really unprecedented, that is, it's never been shown for any other type of blood cancers. But it doesn't stop there. Over the last few years, there's been a number of promising, new effective medications on the horizon that are about to enter the clinical arena. Of all the investigational agents at the moment, the most promising would have to be a brand new group of drugs called monoclonal antibodies. And these include alatuzumab, daratumumab and SAR 650984. Then we have the second generation proteasome inhibitors. These drugs belong to the same family as bortezomib, and they include carfilzomib, oprozomib, ixazomib and marizumab. Then there are the second generation immunomodulatory drug called pomalidomide. Let's first talk about the monoclonal antibodies, because this is by far one of the most effective group of drugs that are about to enter the clinical arena. Alatuzumab is a monoclonal antibody that was first investigated in the use in myeloma. It recognises and binds to a protein on the myeloma cells called CS1. The way that alatuzumab works is mainly by enlisting the help of natural killer cells. One problem, however, is that people with multiple myeloma have very low numbers of NK cells, natural killer cells. So when used on its own, alatuzumab is not very effective for multiple myeloma at all. However, if we combine alatuzumab with another drug called lenalidomide or Revlimid, a drug that is well known to increase the number of NK cells in people with multiple myeloma, this combination works very well. Alatuzumab is very well tolerated, and its future use will therefore have to be with lenalidomide. Currently, phase 3 trials are ongoing with combination of alatuzumab, lenalidomide and dexamethasone. Daratumumab is also another very effective monoclonal antibody against multiple myeloma. This antibody recognises a protein on the surface of the myeloma cells called CD38. Unlike alatuzumab, daratumumab is very effective on its own against multiple myeloma because not only does it rely on NK cells, it can also kill the myeloma cells by stimulating the series of chemical reactions called the complement pathway, causing the cells to rupture with holes being punched into the myeloma cells. In addition, daratumumab can also bind the proteins on the surface of the myeloma cells, signaling for the myeloma cells to commit suicide. Even though this drug is very effective on its own, it's even more effective when we combine it with lenalidomide and dexamethasone. Currently, phase 3 trials are ongoing with combination of daratumumab, lenalidomide and dexamethasone for the treatment of patients with multiple myeloma. Then we have the second generation proteasome inhibitors. These drugs belong to the same family as bortezomib, and there are a number of drugs within this family nowadays. The ones that are most advanced in clinical trials would have to be carfilzomib. Like bortezomib, carfilzomib is given as an intravenous infusion. It's very effective in treating myeloma in patients with multiply relapsed disease. The one advantage that carfilzomib have over bortezomib is that it does not cause peripheral neuropathy. Currently, phase 3 trials of carfilzomib have been completed in combination with lenalidomide and dexamethasone. And this combination have proven to be very effective and can induce a response that can last in excess of 2 years in patients with multiply relapsed disease, which is very impressive indeed. Oprozomib, ixazomib and marizumab are all second-generation proteasome inhibitors that have also shown to be effective in patients with relapsed and refractory multiple myeloma. However, they are still in early phase clinical trials, phase 1 and phase 2 studies. Oprozomib and ixazomib have an advantage in that they exist as capsules that can be taken orally, so they are more convenient. Marizumab is given as an intravenous infusion. What about second-generation immunomodulatory drug? Currently, we only have one new agent called pomalidomide. Pomalidomide has already been approved by the Therapeutic Goods Administration of Australia for the use of patients with relapsed multiple myeloma in Australia. You can see here that pomalidomide has a very similar chemical structure to lenalidomide and thalidomide because they all belong to the same family. As more and more scientific breakthroughs are made in the laboratory, the only way that this can be translated to clinical practice is via clinical trials. You may be asked to participate in clinical trials at some point during the course of your disease, so I just want to briefly touch on this. Now, for a drug to be proven effective, it has to go through a number of phases of clinical trials. The first and most earliest phase is a phase 1 clinical trial, and this is all about establishing safety, all about finding the optimal dose of drug that can be safely used. During this phase, we can get a glean of whether or not the drug is effective or not for the disease in question. These trials are generally small trials of up to 30 patients. Phase 2 trials is when we know that the drug is safe, we've found the optimal dose, we think the drug is effective, but we want to know whether the drug is effective enough to proceed to a phase 3 clinical trials. During phase 2 trials, more information about safety is being collected. Phase 3 trials are much larger trials, typically involving hundreds of patients, sometimes thousands of patients. And this is the final phase of testing before the drug is approved if the new drug is found to be more effective than the old drug. Typically in phase 3 trials, the new drug is compared to the best standard of care. Phase 4 trials is usually post-marketing trials, that is, all about finding more safety information and long-term side effects. The main points I'd like to make about clinical trials are these. Firstly, a person will not be asked to enter a clinical trial at the expense of optimal care. As mentioned, the trial protocols are stringently scrutinised by the Board of Ethics to ensure that any potential benefit of the new drug can justify the potential risk of the trial. You need to remember that any therapies under investigation in phase 2 or 3 trials would have been proven effective before in earlier phase trials. Commonly in phase 3 trials, it will be a randomised control trials. That is, the new treatment will be compared to the best standard of care in the anticipation that the new treatment will be at least as good as, if not better than, the current standard of care. Then there are a number of other supportive measures that you need to be aware of to prevent disease-related complications. First is protection of the bone. As myeloma actively destroys the bone, your doctor will choose to put you on a medication called bisphosphonate, that is a bone strengthener. Examples of bisphosphonate include pamidronate, otherwise known as Iridia or APD for short, or zolendronate, otherwise known as Zometa. Both of these medications are given through the veins and they are very, very effective. Clodronate, otherwise known as Bonifos, exists as a tablet, but they are less effective. One of the important complications or side effect of bisphosphonate that you need to know about is a complication called osteonecrosis of the jaw. And this is when a patient develops a small non-healing chronic ulcer after an invasive dental procedure. And this is because bisphosphonate prevents bone breakdown, which is required for the healing of the bones after an invasive dental procedure. So to prevent this, you need to have a dental checkup prior to commencing bisphosphonate therapy, and you need to let your doctor know if you have an upcoming elective dental procedure so that your doctor can stop the treatment a few months beforehand to avoid this complication from happening. Your doctor may also choose to start you on calcium and vitamin D, especially if you're on bisphosphonate, to optimize bone formation. Protection of the kidneys is very important because, as mentioned, people with myeloma are at risk of kidney damage. You need to have adequate fluid intake to ensure adequate blood flow to the kidneys. I often tell my patients to take a total intake of 2 litres per day, and that's both diet and fluid. However, it's important that this can only be done if you don't have any other medical contraindications, so you need to check with your doctor first before doing this. Avoidance of drugs that can harm the kidneys is also very important. So you need to avoid analgesic drugs such as non-steroidal anti-inflammatories, and talk to your pharmacist or your doctor every time you start a new drug. So overall, what is the likely course of disease in a person who's diagnosed with multiple myeloma? At the moment, multiple myeloma is still not a curable disease, although I do hope and anticipate that this will change in the not-so-distant future. With more newer and effective treatment options on the horizon, you can see that this graph is set to increase until such time that we can find a cure for this disease. Now, I personally believe that we are making significant gains with respect to finding a cure for multiple myeloma, but I will leave you on that note. I hope you found this talk helpful, and I wish you and your family every best in your journey with multiple myeloma.